I used to work in an asthma clinic and a diabetes clinic and a hypertension clinic, and you'd start off with similar drugs, but there were those that would be fine, and others would still come back, and you think, what's going on? And then you would give some, maybe the drugs in a different dose, a different formulation, different order, and you'd suddenly unlock it for them. Or you'd realize then maybe it wasn't the asthma, there was something else going on. And that's what we do all the time in medicine. We just review the diagnoses. And I think the other problem with hormone care, menopause care, is that it's often still owned by gynecologists.
Well, it's an absolute pleasure and an honor to have Dr. Louise Newson on the show today. Welcome.
Ah, thank you. And thanks for inviting me.
I've been wanting to have you on the show for so long now because our audience, there are many people who don't know you, and I'm shocked because you are making quite the impact in menopause. And I honestly do not know any other menopause doctor out there who works as hard as you do and just made as more of an impact on how women get their information about menopause. So first, I want to thank you for
Thank you.
you're such a pioneer in this space. And it's not easy to navigate either. So it shows that you just have a true passion. You're absolutely genuine. I can feel it. You can just all your social media, your podcast. It's amazing. So you've just on such a mission to educate like every single woman out there who is going through menopause or will go through menopause. And I learned so much from you, and I absolutely believe in you. I support you 100%. So,
Thank you. That's very kind.
yeah, no, everybody, I'll have links to your podcast in the show notes. I literally was listening to the one you did with your daughter. And even though it's not about menopause, it's about hormones. And I have my own daughter is 24, and it was such a brilliant episode. And I was thinking, gosh, this is so interesting and so important to know, to hear how you're also helping younger women. And I always say menopause starts in childhood, right?
Yeah, I see a lot of women with premenstrual syndrome, PMS, or premenstrual dysphoric disorder, PMDD, and postnatal depression, all hormonal imbalances. So if I can help any age women is great, but actually helping women in their 20s, it will actually change their career, their pathway, their future health as well. So it's really rewarding.
Well, with all of the drive that you have, I don't know where you get your energy from. What keeps you going? Where does this motivation come to keep this conversation forward around hormones and women's health?
Well, actually, for my family, it's not easy doing what I do, and I do get tired. And every time I say to my children, do you know, I just want to stay at home and make cakes and look after you better, they're like, you get back out there, you don't stop. And oh, really? And but also my patients. I do a clinic day on a Monday, and I did post about this Monday because I felt so cross because I listened to stories in my clinic of women who are given antidepressants, antipsychotics. One lady's 54, and she was told by a menopause specialist, Mrs. Smith does not have symptoms suggestive of estrogen deficiency. How does this woman, this doctor, know that? Because the woman's telling me she has had back-to-back headaches, she can't sleep, she has anxiety, and she's sweaty at night. So does this woman have some magical powers? But also, do you have to have symptoms? She's 54, she hasn't had a period for 2 years. She's got a risk of osteoporosis and heart disease and inflammatory conditions. So what makes other doctors be so controlling of patients? And I think it's the injustice to women that keeps me working, because this lady who I saw in the clinic, she's one of millions of women globally who are being told wrong information with outdated science by controlling doctors. And it's wrong. Like, it's 2025. We need to move forward in the conversation and allow women to choose. It's all about choice, my work. It's about information giving and choice. And the choice is taken away from women. And I find that really sad.
Yeah, I agree 100%. 100%. It's like it's shared informed decision.
Absolutely. Yeah. And women can choose so much more actually than they could do before. And I choose whether I exercise or not. I choose what I eat. But somehow having natural hormones is really hard to choose because we keep being told, no, you can't have, or it's too dangerous. Like, why? People let me do other things. And also, women are given drugs with far worse side effects
Yeah.
and risks than hormones. Yet there's this controlling nature of the establishment.
It's a real pity. And I guess it's because there just isn't menopause training or very little in medical school. And this is where we're
Yeah.
trying to change. But then there's the whole black box warnings that we have on if you do get to that step. And of course, we've had all these amazing menopause experts fight the FDA to try to remove that label. But I get the same thing in my community over and over again. Women who are they're clearly in menopause or perimenopause, and they're completely stuck and they don't have the information. They're listening to you, they're listening to me, they're reading books, they're trying. But what about the woman who isn't even trying or doesn't really know or just has no clue? And then you go to the doctor and the doctor isn't informed. And this happened yesterday. A friend of mine said, my mom's listening to this and she's sending me articles from Harvard, from the Mayo Clinic, which you go, oh, well, that's sounds reputable. But when I read the article, I'm like, this is old information. And so how do you beat that even? And if your doctor, and when we met in person, actually at the European Menopause and Andropause Society, I was kind of dumbfounded sometimes because I was in the audience there listening to these presentations. And this is a menopause conference. And I was kind of questioning, why are we still talking about and researching synthetic hormones? It seemed to be that was dominating. And this is Europe, which I think is more forward thinking in terms of bioidenticals, but nobody was using the word bioidentical. The guidelines, they weren't talking about treating an asymptomatic woman prophylactically, despite all the presentations that we got on the research showing the loss of hormones lead to a decline in bone density and increased risk of cardiovascular disease and dementia, like all these other silent killers. Okay. We don't feel that, right? We don't feel our bones getting brittle. So I was sitting there, I was like, I wanted to speak up because I was like, God, I'm the only one. I stayed quiet until you stood up and you voiced everything that I was actually thinking. So how do you feel about these current menopause guidelines, and how should doctors interpret them to protect women's long-term health, not just treat symptoms?
You see, it's very confusing, isn't it, when people talk about guidelines? You see, my clinical practice comes from evidence-based, but guidelines aren't always based on all the evidence. And I don't work with pharmaceutical companies at all, and I don't work with other brands or products. So I don't have another agenda other than to try and help women to get the education that they need. So when you look at who's written the guidelines, when you look at the pharma involvement, that can skew things and opinions. And also, my work also comes from a huge amount of clinical experience and knowledge, so I can really individualize care. Guidelines are, the word implies, they are guiding people to help the majority, but not those individuals. So I did ask a few questions as you witnessed to the panel. And one of them was just a very simple question about what's the evidence for the blood test that they recommend in the guidelines to diagnose menopause at a younger age. And as you witnessed, they couldn't answer the question because there isn't evidence. And then the other one, I didn't ask the question, but Professor Steve Goldberg did, whether the NICE menopause guidance, whether they took into account the difference between the natural bioidentical or body identical hormones and the synthetic ones. And the key topic advisor on the panel said, no, we didn't. We put them all together because she was worried there wasn't another randomized control study they can use. Well, if there isn't a randomized control study, that's fine, but don't pretend that older hormones are the same as newer ones. That's like saying we're doing a study on fruit. We've used apples and bananas and we find that all fruit is yellow. Like apples are not yellow. It is that binary that we need to be thinking. So there's confusion, and you could hear that in some of the presentations. People were being very confused, and then they dispel confusing information. And then it was a big audience, there's several hundred in some of the lectures, and you could see people being a bit confused. But when you've got professors on the stage who are lecturing, and I used to do it many years ago, I would think that what they said was 100% true. I'm lucky that I have the time to read the papers, to understand the evidence. So then I can ask actually quite simple questions. But it's quite shocking, actually, how people believe what they want to, or they read what they want to. So there's this willful blindness of moving the conversation forward because they've got unfounded fears about hormones as well, and that's threaded through their presentations. But also, what saddened me at that conference, that I didn't go to any lectures where they talked about patients and women. It was all about slides and data. And I feel that's really sad because every time I give a presentation for healthcare professionals, I'll always start with a story of a patient and then end it, usually with the good news, how she improved, because it was so about the risks, but not thinking about the women. There wasn't anything about mental health. There wasn't anything about the injustice to women. There wasn't anything about the risks of not having hormones. And I found that as a real shame because I know I spoke to a lot of people after the conference who said, you know what, I'm now more confused than when I
It's
came. And
terrible.
that hasn't really helped me prescribe and it hasn't helped me with my patients. So it's fine to have academic conferences, but as busy clinicians, people want to know how to help the person sitting in front of them.
Yeah, and it is like you said. I appreciated that when you said, "Well, these are just guidelines. It doesn't mean they're hard set rules, right? We have to take the patient one by one." Well,
Absolutely. And I think this is a problem with medicine. I've been qualified for many years now. And when I started practicing medicine in the 1990s, we didn't really have many guidelines. We would work from our peer review, so what our doctors, other doctors had taught us, but also the evidence as well. And we would always deal with uncertainty. And now there's more and more and more guidelines. It's so hard to keep up with them. But guidelines are not like stuck. They're not lawful. We don't have to abide with them. If we've worked through the guidelines and the patient's still suffering, what do we do? Go, oh, sorry, the guideline says. Of
yeah.
course, we individualize care. We share uncertainty with patients. We share potential risks and benefits, and we involve the patient. And in the 1990s, we never involved the patient. We basically said, here's your treatment, off you go. And there was no internet, there was no social media. But now women are understanding and they're wanting a choice and they're saying, I don't want that antidepressant. I would like to try something that's going to help strengthen my bones, not weaken my bones. And I'd like to try some hormones. And I love these conversations, but a lot of doctors don't like patients being in control of their health.
Mhm.
And you could see that in the conference. It's a shame.
It is a shame. So that's why I always recommend women, if you don't feel your doctor is up to speed on hormones, because I think I went through the Institute of Bioidentical Medicine's menopause method with David Rosensweet. It's all about training doctors on how to help the women treat the women through menopause. And I was just there. I'm a gerontologist. I'm not a doctor, but I was impressed because you do have to very often be with this patient returning over and over again to try to tweak their formula, or maybe it's worked. So you can't just give the one size fits all and say, here, go on your
No,
way.
and it's the same in any aspect of medicine. I used to work in an asthma clinic and a diabetes clinic and a hypertension clinic, and you'd start off with similar drugs, but there were those that would be fine and others would still come back and you think, what's going on? And then you would give some, maybe the drugs in a different dose, a different formulation, different order, and you'd suddenly unlock it for them. Or you'd realize then maybe it wasn't the asthma, there was something else going on. And that's what we do all the time in medicine. We just review the diagnoses. And I think the other problem with hormone care, menopause care, is that it's often still owned by gynecologists. Gynecologists are wonderful at looking after our pelvic gynecological organs. But when you start to talk about brain health and bone health and cardiovascular health, it's a bit out of their comfort zone. And also, I think people are scared that what if they make a diagnosis of somebody's memory problems and they've got dementia or they've got another condition? How do we do that as a doctor? But as general physicians, we're used to looking at all sorts of differential diagnoses and trying to work through. And some women will have both. I've got patients who have dementia and are taking HRT for their menopausal symptoms. That's fine. We need to just be more inclusive. Some of it feels a bit like a sort of club of people who are gynecologists controlling the narrative for women.
Hmm. Yeah, no, it's clear that we need definitely more education in this, and women as well. What I really appreciate about David's program is that he was teaching doctors to teach their patients and sort of how to self-titrate, like in between sessions. You don't have to suffer. It's not working for you for the next 4 weeks. Like, here's a chart. kind of follow that. You're helping the doctor to help you by treating that. Now, that's very clear if you have outright symptoms, but if you're asymptomatic, I mean, when I say asymptomatic, I mean, you're not feeling the other possibly 100 other symptoms that you're having. So if people like me who, when I was crossing through my 50s, I thought, well, I don't want to fall off a cliff. It sounds horrible. And of course, this is part of social media as we get so scared of what's going to happen. And it doesn't have to be that way. I said, well, I want to protect my bones, my heart, my brain. Like, I don't want to have to wait until I have a fracture or I get a diagnosis of you have osteoporosis. And then, okay, let's talk about hormones. I think it's kind of like saying you're in this, let's pre-diabetes zone, or let's wait until you're diabetic and then I'll treat you. And it's so much harder to reverse. But again, medicine in the Western world, we're not working at lowering the risks or taking a preventative approach.
Yeah, and I think this is where traditionally doctors have been trained to treat disease rather than prevent it. But we need to change the conversation because we're living longer, we're getting more diseases as we age. So the more we can prevent and delay diseases, it's got to be better for healthcare systems as well.
Yeah. And it's not only about hormones. I mean, there should be a whole other discussion,
Absolutely.
but that certainly helps. And when I went through my journey and just starting to learn more about hormones and what should I do, my mother died of breast cancer at 57. And so, of course, my first question is, do hormones cause cancer, or what do I do? I didn't know as much back then, but I wanted to understand the risks and the benefits of hormone therapy. But based on what I kind of had learned so far, the question I really asked was, what are the risks of not taking hormone therapy? Because I understood there was some lowering of breast cancer risk at that point. And most women are not asking that question, but I actually encourage them to ask it. What do you think of that approach?
Absolutely. I think that is so important because the last 20 odd years, it's always about risks of hormones, and they're unfounded fears often. But we do need to be changing the conversation to think, what are the risks of not having an evidence-based treatment? What are the risks of not having hormones that work throughout the body that are biologically active? And it's fine. It's a bit like saying to a woman, what is your risk of not exercising?
Yeah.
You might be fine. Like, there's lots of women who never exercise and they live to 100 and they're fine. But we know it's associated with increased risk of heart disease, dementia, cancers if you don't exercise. And it's the same with hormones. Just be aware that there are risks to your health if you don't take hormones. But it's up to you if you take them or not.
Exactly. And I always say you can't out hormone a bad diet and lifestyle. And we have to think about detoxification pathways, especially whether it's your own hormones or you're taking them and not exogenously. So what do you think about this approach in terms of taking hormones? Great, fine, but what other lifestyle practices do you think that we...
Well, it's great you're asking, but it's really, really important, whether a woman takes hormones or not, is that she looks at her lifestyle. Some people think that if they take HRT, it does everything for you. And sometimes actually people who are anti-HRT think that people like me, all we do is give HRT, give HRT. But actually, HRT is really good and it helps me with so many symptoms. But of course, I still have to exercise. Of course, I still have to eat healthily. I have to think about whether I'm going to drink alcohol or smoke or whatever. So it will help the hormones to work properly. I can take all the hormones I need, but if I don't do yoga for a few days, my head just goes. I can't multitask. I can't sleep well. I can't think in the same way. Well, that's not my hormones. That's just because I need to exercise. So, and that's what's really important. And like you say, like our gut microbiome is improved by hormones, but also what we eat. So if I was going to eat a burger and chips every lunchtime and wash it down with a bottle of wine, well, the hormones are not going to work as well, and in my liver or my systems as well. So it just goes without saying, really, that you have to be thinking about lifestyle as well.
I think sometimes we look to things that are the magic bullet. And whenever somebody listens to a podcast or read a book, it sounds like it's the magic bullet. And that's why I keep sitting, banging the drum, like we need to still do all the work. I think we just would love to just not have to do it. And I also shy away from the word protect. I correct myself even. And I just say, well, I think it lowers the risk. it should lower
Of
the.
course it does. It lowers risk. There's no guarantee with anything. Absolutely. And that's what's really important, especially when people think about breast cancer or any cancer. Women will still get breast cancer whether they take HRT or not. They probably won't increase their risk. It might even reduce if they take HRT. But we can't protect ourselves in cotton wool and never go outside in case we get struck by lightning or get run over by a bus. But if we are so petrified, then we don't have to go outside. And so a lot of the conversations are for the majority of women. And we have to wake up to the fact that globally, 95% of women are not prescribed an evidence-based treatment. All menopause guidelines state that HRT is first line for the majority of women. So even if you look very simplistically, we are doing women a disservice as healthcare professionals. And also, most women do have symptoms. Most doctors go into medicine to help their patients feel better. So we're doing a disservice because they're suffering, but we also know there are health risks. Like we wouldn't deny a blood pressure lowering treatment and watch someone have a stroke.
Yeah.
But we are doing that with HRT, and I don't quite understand why this is happening.
And especially when we've been, I guess we or doctors in general have been passing out birth control without any question, and what patients are accepting it. I was the same when I was in my 20s. I like, yeah, bring it on. I need to fix my skin. I need to protect myself from having a baby. I didn't want it at the time, but I don't. There was just no question. So when I get women who are so afraid of taking hormones, I said, "Did you ask? Did you take birth control?" And they said, "Yeah, of course." Well, then why?
Yeah, it doesn't make sense.
Yeah,
it doesn't make sense. But you see, when I speak to a lot of doctors about the difference between synthetic hormones in contraception and natural hormones in HRT, they often look really blankly and say, "Oh, you've lost me there, Louise. I don't really understand." And that is a real problem. And women are understanding more than others about the potential risks of contraception and the many benefits of natural body identical HRT.
Yeah. And we know that estrogen, our natural, let's say estradiol, is anti-inflammatory, right? And I know that you studied a lot about inflammation. So why don't you talk a little bit about that piece of an anti-inflammatory effect?
Yeah, so inflammation is a good and a bad thing, right? We need some inflammation to protect our bodies. If someone sneezes over me, I do not want to get an infection. So our body has white cells, it has immune cells that fight infection all the time. And it also is mopping up damaged cells, repairing our cells. And that's the inflammatory cells, the immune cells do that as well. But they can turn against us as well. So they can become pro-inflammatory. If we have too much inflammation in our body, it can damage healthy tissue. And we don't want that. So our bodies are amazing how they're fine-tuned, really. And these cells they're like our sort of armor. They're like guards, really. But they have to fight, but not fight too hard. They have to protect, but not protect too hard. It's a balance. And so in my pathology degree, I spent a lot of time learning about how these cells work and how different microenvironments can alter their effect. What I didn't learn, and I did learn 20 years later, was that hormones can have a massive effect, good and bad, depending on the levels of how these cells work. So if you've got low estradiol, then the estradiol receptors on these cells, especially the macrophages, don't work properly. So they're not stimulated. So if you've got low estradiol, your macrophages don't work properly. They actually change the number, they change the way they work, they change the chemicals that produce from them. They become quite pro-inflammatory, so they increase inflammation. And that's why you've got this increased risk of inflammatory disorders, so heart disease, osteoporosis, diabetes, dementia, Parkinson's disease, inflammatory bowel disease, autoimmune conditions, because the macrophages, the immune system is primed in the wrong way. But give it back the right amount of estradiol, the estradiol will stimulate those receptors and they'll work better. So you get the right balance of chemicals, cytokines that are produced, you get the right number, they work well, they're happy. And that's the same if we eat an inflammatory diet. If I went and had my processed burger, it would increase inflammation, make those macrophages work in an unhealthy way. Whereas if I had some organic meat or some fresh vegetables, it would be different. So, and we're more aware of inflammation because it's the inflammatory diseases that kill us, basically, and make us ill and make us sick and make us need other drugs. So, knowing the basis of how these hormones work in inflammation, and it's the same for progesterone and testosterone, is really crucial when you go down in a molecular level what's going on with these hormones. And this is just basic science. This is just how our hormones work. This isn't like a new theory. This isn't a new drug. This is just basic science that's been forgotten for decades.
So, if I understood correctly, it's when you're at a low estrogen state, then
Yeah,
macrophages are not working optimally to protect,
absolutely.
and
Yeah.
that's what's increasing the inflammation.
Yeah, so it become pro-inflammatory. They increase inflammation. They change from protecting us with their shields to getting their daggers and swords out. And they fight against us. And that's why autoimmune diseases will increase in the late 40s, early 50s in women.
Interesting. So so in the end, part of the mechanism of action is bringing in estradiol. Then the macrophages are happy and they're doing
Yeah,
their job.
absolutely.
Then that's the anti-inflammatory effect.
Yeah. Yeah, absolutely. Then they get their shields out and they can fight and they're just there on alert. And so that's why, even simplistically thinking about infections, a lot of menopausal women who don't take hormones and say they're more prone to viruses, they've got shingles flare ups, they get a cold or sinusitis every winter. And then they take HRT and they say, oh, I haven't had an infection for ages. No, because your cells are protecting and working better.
Are we seeing these effects both with bioidentical and the synthetic
No,
estrogen?
so you won't get them with the synthetic hormones because both like the synthetic ethinyl estradiol or the pregnant horse's urine, they are synthetic, so they block the receptors. And the same with the progestogens. And in fact, the progestogens can be quite nasty. They can block other receptors as well. So if you think of the hormones like a key and the receptors like a lock, you've got the wrong key going in the wrong lock, basically, but it blocks that lock. So not only does it not unlock and you've got these good beneficial reactions, it stops the natural hormones going in as well. So that's why actually taking hormones is worse for some women than not taking anything because you're affecting inflammation. And we've known for a long time that, women who use synthetic contraceptives can have an increased incidence of autoimmune diseases, for example, or heart disease and stroke. And that's because they're blocking the natural receptors.
Do you think part of the problem with doctors not understanding menopause is that they would get that information? They would hear what you just said in terms of the synthetic, and they don't understand the difference
Yeah,
synthetic.
definitely. I mean, they don't understand. And even if you think about the progesterone only pill, it's called the progesterone only pill, but it's not progesterone, it's a synthetic progestogen. So even I was reading just on some guidelines recently, and they said, oh, if you have migraine or a risk of clot, you should take the progesterone only pill. Well, that increases risk of clot. It doesn't make sense, but people somehow think that a low dose hormonal contraceptive is fine to take. And that's partly because younger women have lower risk of all sorts of conditions. Everything worsens as we age. But it's also this massive misunderstanding. And it's happened for decades. I mean, I know a lot because I've read a lot about the history of hormones and how they work in a molecular way. But most people just see it as estrogen, progesterone, and they think it's all the same, and it's not.
And even in the research, I've come across studies that have mixed. They say
Well,
that
they have. So this is a big thing when you look at dementia risk reduction. So there's a lot of confusion out there. Does HRT reduce dementia? And there's mixed messages, and that's usually because people lump together natural and synthetic hormones. When you just look at women who take the natural body identical hormones, they do have a lower incidence of dementia. And of course, it makes sense the way that the hormones work in our brain. But if you suddenly gave people synthetic hormones that block the receptors, you're not going to get the same neurogenesis. You're not going to get the same blood flow to the brain. You're not going to get the same neurotransmitter balance. You're not going to get the same reduction in inflammation in the brain. So of course, it's going to be different.
yeah. And that's part of the problem. And this is just the story I had yesterday with my friend and her mom. And she's throwing all this Harvard and Mayo Clinic stuff. And it was clearly saying bioidentical is a marketing term. It is not better. It is not like, I don't know how to fight that. And I mean, what do you say? I'm not a menopause
Well,
doctor.
I think that's a lot of what I've always done in medicine is you go back to the basics, actually. And someone contacted me recently and said, how are you going to change the guidelines? How are you? Like, firstly, I can't do anything on my own, but all I can do is unpick the science and then explain it in a simple way that other people can understand and make choices.
Mhm.
So if the doctors aren't prepared to understand, then that's their problem, not my problem. But
Mhm.
it is just basic physiology and pharmacology that perhaps they've never thought about. And I didn't think about it for many years because as a finished physician, you're busy, you're seeing lots of patients, you're seeing patients with all sorts of conditions, and you do what you're taught. And then you go to the guidelines. You don't read the evidence. You don't sit down and think about the biology and the physiology of what's going on. It's only because I've got that sort of brain that I've spent hours upon hours thinking about it.
Yeah, it's your passion. It's clearly, and most doctors they don't have a passion in menopause. I mean, you've taken it next level, which is why we're all listening to you and learning from you. And I absolutely trust you. So I'm so grateful for that. But I want to move on because you're one of the most well-known menopause doctors in the world, and you've helped change how we're thinking about hormone therapy. But one hormone still doesn't get enough attention, and that's testosterone. Why is that?
Do you know what? I'm sort of hesitating because I'm really cross today because our Women's Hour over here on Radio 4 did a feature about testosterone and they were just making fun of it. And I just felt like shouting. Well, there's no point because they can't hear me all the way down on my phone. But there's this misunderstanding. Even the word testosterone's from the testis. Like, hang on, we don't have testes, but we have ovaries. But it's just a natural hormone that has been labeled and branded, and part of it is because of the history of testosterone. When they were trying to make a synthetic progesterone, they made a synthetic testosterone by mistake and then realized it had these effects on men. So then they started to market all these weird and wonderful testosterone-like substances, which to the lazy or the uneducated, they call it testosterone. So we've all seen pictures of people who inject testosterone at weird doses, weird amounts, and they've got this weird body shape. Some of them will have heart disease. You know, there are risks, but that is not testosterone hormone. That is not the testosterone I prescribe in my clinic. So that's one thing that's really important. But the other thing is it's a natural hormone for women. It's a biologically active hormone. And we produce higher amounts of testosterone than estradiol when we're younger. So we know it's safe. Like it just seems madness that there's this control. So one of the problems is we haven't got loads and loads of studies in women, but we have got studies, but they're ignored like a lot of things in medicine. We know that it helps with libido. Everybody, even the people that don't seem to like testosterone, agree with that. Now, we know that libido reduces in women who are menopausal for lots and lots of reasons. And the guidelines say we can give testosterone to women who are on HRT with reduced sexual desire. Yet some menopause societies take it a step further and say, no, 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 they have to have HSDD, hypoactive sexual desire disorder, which like they've made it a disorder for women. Like they have to be severely psychologically distressed with their reduced libido. And like, what? Hang on, stop. Like, let's just think about this. But we know that the hormone works on every cell in our body, including our immune cells. It works in our brain. We know that when women don't have testosterone, they can have low mood, reduced energy, poor concentration, reduced stamina, poor sleep, muscle joint pains, headaches. And we know from our clinical practice, some of it we've written up and have published, but lots of other people globally have known for many years that mood, energy, concentration, stamina can improve with testosterone. Yeah, on this radio this morning, this woman was saying it's the same as placebo. And others say, well, it doesn't. And we don't know about the data and the safety. Well, firstly, it's a hormone, so it's pretty safe. Secondly, I don't believe that the placebo effect is like that. And I personally would not be able to work as a doctor without testosterone because my brain had just gone. I couldn't think and remember. Yeah, you could tell me that it's my diet, exercise, or whatever, but it's not because I've had times where I've forgotten my testosterone and my brain's just gone. And recently I was trying from the cream to the gel because I just thought I'd try a different preparation. And that weekend, my husband was saying, "What's happened? Like you're falling asleep. You're really weird. Like you're not listening to me. Have you changed your hormones?" I'm like, "Oh yeah, I did actually, because I was just trying." No, I wasn't expecting it to be any different. I just thought it might be easier to try the gel. So I just don't, it doesn't like, but also we've got really good studies in men about testosterone. We've got really good studies in men about statins and blood pressure treatment. If I'm prescribing, I use those male studies for women because we don't have good women's studies about statins and blood pressure.
Mhm.
Yet somehow we're not allowed to use the male studies about testosterone. We have to have our own female studies. So it's so incongruous. It doesn't, but we can wait until the evidence. We can wait until different guidelines. If I have a woman in front of me who's got low testosterone, symptoms suggestive of testosterone deficiency, and wants to take testosterone, I don't really see why we can't give it.
Yeah. Well, very often too, we don't have the female prescription in many
Well,
countries.
this is a real problem. So then we have to fiddle faff around with a male amount. It says we don't have anything licensed over here. We are lucky we can get the female cream that's licensed in Australia, but it's private, so that's expensive. But we also found with some of our data that women who are on other medications, including antidepressants and drugs such as gabapentin and pregabalin, once they're on HRT and testosterone, we can deprescribe these drugs. And again, if I say to a patient, would you prefer to be on testosterone, which is a natural hormone, or gabapentin, which increases your risk of dementia and is quite an addictive drug that causes side effects, which do you want? Again, patients can choose. I haven't met someone that wants gabapentin more than testosterone, but if they want it, that's fine. But again, it's this control in medicine, like this woman on the radio and others, they're just saying, no, there isn't evidence. No, you can't have it. It's the same as placebo.
That doesn't make any
It just
sense.
feels a bit controlling, really.
Very often we think about testosterone being men, muscles,
Yeah.
emotion, so sex, libido, but it does so much more in terms of the motivation and your
Of course it
energy.
does. Yeah. I mean, we found from some research that women who take testosterone are more likely to want to exercise, like significantly over 70% more likely. That's not a bad
God.
thing. But then we've got professional athletes that aren't allowed to use testosterone because of the anti-doping. And that is really sad because there are women out there who are professional athletes who are on HRT, which is allowed, but they have severe symptoms of testosterone deficiency, yet they're not allowed to compete if they use testosterone.
Mhm.
But they're really struggling with their symptoms without testosterone. And I don't understand how a regulatory body can decide about someone's future health.
Yeah, that's all. It's a big issue for athletic women, and I hope this changes because I understand the anti-doping policy, but I think this has been a long
Well,
gone.
the
It's
problem with the anti-doping policy is they're looking at synthetic testosterone. They're
mm,
forgetting that testosterone is a natural hormone because some of the guidance says women should have an alternative. What is an alternative to a natural hormone? There isn't one.
yeah. You mentioned actually testosterone is quite high when you're younger. I mean, or that we have more testosterone than estrogen when you're younger. Is this change? Those ratios change as we get older? We get
Yeah, so often testosterone starts to reduce in their late 20s, early 30s. So increasingly in my clinic, I see people who have regular periods. They're otherwise well, but then they have symptoms suggestive of testosterone deficiency and their testosterone levels low. So I think we should be clearer with our language when we talk about menopause, really, because a lot of people are testosterone deficient and they might be fine with their estradiol and progesterone. And that is a real shame because we're not picking it up early enough. And it's the same with men as well. A lot of men are testosterone deficient and it's not been recognized.
well, hopefully that will change. Do you see any changes in the future? When will women have a testosterone gel or cream?
I don't know. I don't know. I think what is changing is women are understanding. So over in the UK, more women than men are prescribed testosterone on the NHS. So that's
Really?
pretty cool, I think. I mean, it's still bad, but it's still good. I think it will change just because women will want it. I really do. And when women, they find something out, they share it with friends, they share it with colleagues, they talk about it. So you can't keep ignoring something. So someday, somebody who writes some policies or guidelines is going to be either struggling themselves or know someone that's struggling. That's, you know,
Yeah, it's going to be someone in policy making who's going to be really
yeah.
affected. I think, yeah, hopefully that will change soon. And I actually, testosterone, like any other like any other hormone, just in general, it has this Goldilocks zone, right? We don't want to have it out of balance with others. We don't want too high, we don't want too low. When I was studying with Dr. David Rosenstreet, he was mentioning in his practice that 25% of the women get their HRT prescription right, spot on the first time, and most of them just kind of need to tweak it and find their Goldilocks zone. And he's looking at not just symptom relief, but he's looking at the whole picture holistically and all the other markers for long-term protection of the brain, the bones, the heart, et cetera. Is this something that you're seeing in your practice too in the UK, about 25?
Yeah, for sure. Yeah. So about half of women who come to our clinic are already taking hormones. So they're coming not because they want to come to the clinic, because they're still having symptoms and they can't get a dose change in the NHS. So about a quarter of women need higher than licensed doses of estrogen because they just don't absorb it through the skin. It's just a basic absorption problem. A lot of people, they're not on the right dose of progesterone. So quite a few women who have PMS or PMDD, we often give them vaginal or rectal progesterone, sometimes at higher doses, which can make a massive difference, especially to mental health. And then testosterone and also vaginal hormones as well. We can't forget the vaginal hormones for a lot of women can be transformational. And then if we start hormones when people are perimenopausal, you're trying to chase a moving target. It's constantly like moving, changing. What do I do? The dose. So it can take a while. And that's why regular reviews are really important if you're still experiencing symptoms. I've met lots of women who come with really quite disabling symptoms and they say, oh, my doctor says it can't be my hormones because I'm on HRT. And then you look and they're like on the lowest dose patch with progesterone, or maybe they've got marinocoilin, so they're not even on progesterone and they're not on testosterone. And it's like, well, okay, you might be stressed because your daughter's just gone to university, but also look, your hormones are really low. So let's just optimize them and see how you improve.
Yeah, this is why I can see why some doctors maybe go, oh, I don't even want to go there in menopause because she's going to keep coming back. And then I have to also spend all this time and extra time and money in
Yeah,
training.
yeah,
Like, yeah, I kind of get why, but the problem is that more than half the population are women. So we're going to have to deal with it
yeah.
one day or another. It's not just a small portion of the population. We can
No.
say, well, I only see a few of those. But last questions. I know I have to let you go. I have a few friends actually in the UK who really want to see a private menopause specialist, but they say that the cost is just too high for them and their GPs aren't giving them the help that they need. So what options do these women have when private care feels out of
It's
reach?
really difficult. It's really hard. So I think first thing is that you can get a second, third, fourth opinion from another NHS GP. A lot of GPs work within, there's more than one in the same practice. So don't feel bad if you're seeing another doctor in the surgery. And sometimes people have like local Facebook groups and they might be able to share, I'll go and see Dr. Blogs because she's really good or he's really good and will prescribe. I would also go with someone else to your consultation. So you've got an advocate with you and actually say, what are your reasons for going against the guidelines? Because the guidelines, I know we've been negative about the guidelines, but actually the guidelines, top level, say that HRT is first line treatment. So why are you going against the guidelines? I think it's worth challenging if you're really getting nowhere with the doctor. And then people do come to our clinic, but they often only come once or twice. And increasingly, women who come to the clinic, once they're on the dose and type of hormone that's right for them, and we write very detailed letters, then they go back to their GPs, and the GPs go, oh, I can see how much better you are. That's great. I will then prescribe. Because there's a difference between starting a prescription and continuing a prescription. And so we do find that a lot of people then don't come back to us, which is great. So I don't think people realize that you don't have to be tied into the clinic. Do you see what I mean? It's absolutely great for me if people don't keep coming back. It's a weird business model, but actually GPs sometimes say, gosh, no, you need antidepressants, da, 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 da. Whereas then if they're on hormones and they're better, it's then harder to take them off you. Do you see what I mean? Whereas if you go and say, I think my mood's going to improve with testosterone, then probably say, well, no, you can't have it. Whereas if your mood really does improve, then it's very hard then to say no. So
These are great tips. So needed them. Now I'm going to go back.
great.
So you said, yeah, one, make sure that you can see several doctors within
Yeah.
the GP system, your NHS system. Two, you come with a friend to advocate for you and bring in some guidelines to help you. And three, you said, well, go invest in that menopause doctor. Just go one or two times.
I mean, we see a lot of people who really can't afford. Sometimes they get 10, 20 pounds from each of their family members for a Christmas present. It's very humbling. And they say, that's the best money I've ever spent. I'm not going to Starbucks. I'm not going to Costa. Every time I would have bought coffee, I'm saving for this consultation. But then it gives them the confidence to then move forward with their NHS GP as well. So because menopause lasts for decades, you forego a few outfits or a few nights out, you might not remember them, but you'll remember feeling well or not feeling well. Do you see what I mean? So you don't want to be tied into something that's a recurring cost. That is a big problem.
Exactly. Well, you get it right the first time, hopefully, and then you just keep going. But Dr. Newson is one of the leading voices in menopause education. If you could just give one piece of advice to help a woman have a smoother transition, what would it be?
Well, download Balance, the free app. Get the knowledge and information that's right for you. Don't be put off, persuaded or dissuaded by other people. Just do what's right and feels right. But know you can change your mind at any time as well.
I love that. Yes, I'll have a link to the Balance app. It's really great. I've downloaded this like ages ago, and it's all free. And I also voted for you for the Louise Newson podcast with the
thank
podcast
you.
awards. Yeah. So if everybody, I'll have a link to that, and they can just vote for you. They got to listen to a few episodes because we want to introduce you to somebody who you probably don't know and is absolutely brilliant in this space. And when I doubt myself, and I even know to go to Chat GPT, and I was like, what does Dr. Louise Newson say about this? I don't want just general menopause information, but I've trained my ChatGPT to be able to
Perfect. Very good.
your advice, which is brilliant. So I know you also have an event coming up in October. Do you have any other exciting projects? You want to talk a little bit how women can learn more from you?
Yeah, so I've got 3 dates in October. So one in London, one in Birmingham, one in Glasgow, which is, I'm going to be interviewed. So it's a Q&A, and then there's going to be a Q&A for the audience so people can put in their questions and I'll answer as many as possible. So I'm looking forward to that. And then I've got a few things lined up for next year as well, which will be great. So there's always things happening, but also I respond to feedback. So I do a weekly YouTube. Obviously, I do my weekly podcast. If there are topics, areas that people want to hear more of, then that's really important. So get in touch through my Instagram, and we just want to move this conversation forwards.
Yeah, I have links to all of your social media in the show notes. The YouTube is a great space as well to watch you and listen to your live Q&As. I love doing that. You can see the confusion of plenty of women out there. And you just hit it one by one. It's just brilliant. Such a good job. I'm so grateful to you and all the work that you do. You're such a pioneer, and keep going.
Oh, thank you.
And
thank you so much.
Make time for yourself too. Don't forget.
Yeah, thank you.
And we'll see you. If whoever made it to the end, which I know many of you have, thank you for listening. Thank you for being here. On YouTube, we finally hit 7,000 subscribers. So thank you very much to you guys for helping us grow bigger and bigger. And thank you, Dr. Louise Newson, and have a wonderful day.